Good afternoon, everyone. My name is Eleni Anslas from Suburban Hospitals Community Health and Wellness Department. Thank you for being here with us this afternoon. Today we have Tiara Hurd from Sibley Memorial Hospital. She's a physician's assistant, and she is going to talk to us today about common growths, winter tips for maturing skin, which as we get older, we always have to take care of our bodies, and our skin is one of them. Before we begin, I just want to go over a couple of housekeeping items, if you will. First, today's webinar is being recorded, and I'll make the recording available in the next coming days. Secondly, questions. We all have questions, especially when it comes to our health. If you would please hold your questions until the end, and when you have a question, you can put it in the QA box on the bottom of your screen. Lastly, and most importantly, at the end of today's webinar, a link will be sent to you. It will link to a evaluation. Please take time to fill out that evaluation. We'd like to know what you got from this presentation, any insights, how you're going to apply it to your own health, and also topics for additional seminars, webinars. So with that, I will pass it on. Tiara, thank you so much again for being here today, and the floor is yours.
Thank you, Eleni. I appreciate the opportunity, and everyone, thank you for taking the time to join us this afternoon. Again, as Eleni mentioned, my name is Tiara Hurd. I am a physician assistant with Sibley Memorial Hospital under Johns Hopkins. Just to give you a little bit of background, I've been a dermatology PA for about probably 17 years now. I started my career in dermatology at Cleveland Clinic in Cleveland, Ohio, and then under more your general dermatology, doing the kind of bread and butter. And then I ventured off and did subspecialty dermatology, more in your cutaneous oncology, focusing more on skin cancers at Sloan Kettering in New York. And then for the past couple years, I moved back to the DMV area and was in private practice for a couple years, getting back into the general dermatology. And now I am back home, so to speak, in your academic medicine, again, doing your bread and butter derm, kind of your cutaneous oncology, skin check, skin cancer prevention, and so to speak, at Hopkins at Sibley. So I guess when Eleni approached me about doing this talk, I wanted to come to the community and just go over some brief common concerns that I get repeatedly during those skin checks, and common questions that patients are concerned about, rightfully so, and go over those, and then just offer some winter tips about taking care of your skin and products that you can use, and that some of my faves and that some of other dermatologists offer about keeping your skin moisturized and hydrated during this winter time and everything gets dried out and kind of itchy. Okay, so with that, we'll move ahead. So the first up is we'll start with the official term of seborrheic keratosis, also known as SKs. Sometimes they may be referred to them as barnacles. I like to call them your wisdom spots, but they are extremely common benign growths of the skin. These growths can be anywhere on the body, but they typically appear on your chest and back. We really don't know the exact cause of them, but we do know they typically can appear in areas where you have sun exposure. We know there's a genetic component, and we know they definitely tend to increase with age. So you get them more as you get older. I always warn patients that they are friendly. They do not tend to turn into anything cancerous, but they can look a little worrisome. So, here's some pictures of them. There's different components or variants of types of these growths. You see the one on the scalp here. It's a little bit darker and larger, and then you have different compared. Some people may only have a little. Some people can be covered in them. They can come anywhere head to toe. And they can also be varying colors. They might be brown or black. Um, they can be on the lower legs or extremities. They may tend to be white in color, so we call them stucco keratosis. On the face, especially in Skin of Color, you might have seen the famous actor Morgan Freeman, who has a lot of them on his face and cheeks. And then people will say, "Oh, I don't like my, Morgan Freeman moles," but we call those DPNs or dermatosis papulosa nigra. But they're actually a type of these seborrheic keratosis. And then on lighter skin, they tend to be what we call lichenoid keratosis, where they're a little bit more pinkish. But again, they're all under these variant subtypes of seborrheic keratosis or barnacles, which are benign, or what I like to say, very friendly. So you can have them for years. Again, they do not go on to become a type of skin cancer. They can be removed. We do remove them cosmetically, but I also always warn my patients that, hey, if we treat them, whether we, remove them with a biopsy or we remove them with liquid nitrogen, also known as cryotherapy, or we scrape them off, they do tend to come back over time. But otherwise, this is one of your very friendly age spots, so to speak, that you will get over time. Okay. Next, we have that's a very common growth that we get, are called cherry hemangiomas, or sometimes they're known as angiomas. This is a very common vascular growth, or what we also say a blood vessel growth, and it's composed of tons of little tiny dilated capillaries, or those little vascular growths. So they can be flat, they can be raised. Again, these also can come head to toe, be on the scalp, face, body. And sometimes I also warn patients, if you ever happen to scratch one or, traumatize one, it may bleed a little bit more than other lesions just because it's filled with so many of those different blood vessels. This is also tends to have a genetic inheritance, but they are also benign. We can also treat these for you if they tend to bother you, or if you just don't like them cosmetically. So again, we can remove them with a biopsy. We kind of shave them off. We can remove them with electrodesiccation and curettage, which just basically means we kind of scrape it and burn it. Or again, we use a method of liquid nitrogen, or also known as cryotherapy, which is the really cold burn. Or you can see a cosmetic dermatologist that does laser. And again, it's not a permanent solution. You do get more over time with that. But yet again, these are more benign growths and friendly, but passed on through genetics. And next up, we have sola purpura, or also known as actinic purpura. And this is just due to you have an exposure of ultraviolet light or sun exposure. And over time, that ultraviolet light or UV light kind of weakens the blood vessels under your skin. And if you have any minor trauma, say you bump your arm or you kick the coffee table, then that causes those blood vessels to kind of leak into the skin. And if you're already on a blood thinner, a baby aspirin or Coumadin or warfarin, then this kind of will exacerbate that. So this is where you might see this increased bruising on areas that, we pretty much kind of bang, unconsciously or subconsciously throughout the day, on the hands, on the wrist, forearms, or even maybe your shins, and things like that. So this is what you might see in as we get older and our skin is thinner, a little more fragile, a little drier. We don't have that supple ness to our skin. So there are products that can help build up the moisture and provide a little bit of protection to it. So some of our favorites are Derm Men for fragile skin and the Aven Cyclophyte, which helps to build a little bit of the collagen. Some other recommendations that I suggest to my patients is definitely making sure you're doing sun protection. In sunscreen SPF 30 or higher, making sure it's broad spectrum, which means it's ultraviolet A and B protective. That means wearing some protective clothing, long sleeve, and just making sure you're protecting as much as you can from any minor trauma or injury to prevent any of those vessels from leaking. And then next we have up that we see quite frequently in clinic that my patients might ask me about are called dermatofibromas, or we nickname DF. These are also another type of benign growth on the skin. And these are little tiny, they're hard, kind of nodules or lumps underneath the skin. And a lot of times patients will notice them either on the back of the arm, they might notice it on the shin or lower leg. And it's just it's a nodule that's filled with macrophages, which are the cells that help with tissue repair. And again, those blood vessels or capillaries. And then fibroblasts, again, those cells that help to produce collagen. And even though we don't know the exact cause of it, they tend to usually be associated with some type of minor trauma. So I know for a lot of my female patients, they'll say, oh, I nicked myself shaving, or someone may have gotten an initial bug bite, or they had a little hair follicle that got infected. And when it heals, the skin kind of forms this little scar or nodule. Again, there's not any propensity for this to form into a cancerous growth later down the road. But it kind of leaves that scar, which sometimes can get a little bit irritated later. You might accidentally scratch it. But I tend to recommend to, just keep the skin moisturized and don't bother it. Sometimes patients don't like the way they look cosmetically and opt to have them removed, but I'm also mindful that in having it removed, whether it's cut out or whether you might use liquid nitrogen to try to calm it down, those are also inducing inflammation, or you might, or cutting it out can actually form more trauma or make more trauma for it. So there's a chance that, it can come back, or that it can even come back bigger. So my recommendation for my patients is that if it's not symptomatic, or if it's really bothering you, if it's not growing, just leave it alone as it is. Okay. And then the next up is that as we're moving into the winter months and, we're in the heat and there's no humidity in the air, our skin is drying out. We're taking those really hot, nice, long showers. And we start to notice, our skin is drying. And one of the things that commonly comes into the office is they say, oh, I have this rough, bumpy skin. And so one form of it is what we call keratosis pilaris, or KP. Some people even refer to it as chicken skin. And this is also a condition that can be kind of inflamed and get pretty severe, especially in the wintertime for some folks. It tends to be associated with eczema and asthma, and it's kind of where those hair follicles are really plugged with keratin. And so in dry skin cells or dead skin cells. And so ideally, you really want to keep that skin from getting too dry. You want to keep the skin moisturized, but you also want to make sure the skin has been exfoliated. So we want to make sure that when we're moving into the winter months, that we're kind of adjusting our lifestyle and making sure that we're limiting those hot showers to lukewarm, short, cool, or short to lukewarm to cool showers, and that we're moisturizing. I know some of my patients are, I don't want to moisturize, or they might moisturize just the face and hands, but we want to moisturize the body as well. We want to avoid using harsh or drying soaps. I know sometimes people are used to using Ivory or Irish Springs or Zest, things like that, or the heavy bar soaps, but we want to use something that's a little bit more moisturizing and hydrating. And then things that are going to kind of slough off that kind of top layer of the skin, those are dead skin cells, things like lactic acid or salicylic acid. And now there's a plethora of options that moisturizers and body washes that have these keratolytics, as we refer to, that have salicylic acid and urea, or body oils that help to kind of not only just slough off, but help to put moisture back into the skin. And these are some examples of some of my favorites. Some of you might have heard of Lachydrin, or Amlactin is another name that has the 15% lactic acid. Another favorite is urea. Cetaphil has brand. One of my favorites is a 20%, but urea can go all the way up to 40%. Probably wouldn't recommend the 40% for the body, but it's a great one for the feet, which can, the skin on the feet is much thicker than the rest of the body. So 40% urea is a great option for when the skin gets really dry and thick, those soles get really thick. And then as far as salicylic acid, you have the CeraVe Sal Acid or SA lotion for the rough and bumpy skin. And CeraVe also has the added ceramides and vitamin D that helps with putting added moisture back into the skin. Okay. Okay. And then the next thing, as I mentioned, again, when those months, winter months, fall to winter months start changing, and everybody comes in with, again, what I call the winter itch. And I say, the drier you are, the more you itch, the more you itch, the more you scratch. And then, so in efforts to try to prevent that, we want to stay ahead of the game. And so a lot of the factors that contribute to that is, low humidity, frequent bathing, the harsh soaps, as I mentioned before. And there's other factors. Those are some of the environmental factors, but, disease states that also can sometimes contribute to excessive dry skin. Even when you say, oh, a patient may say, well, hey, Tiara, I am moisturizing. I am actually using greasy ointments and I'm still really, really dry. Then we have to start looking at things like, well, do I have eczema, or how's my thyroid levels? Is there menopause? Do I have diabetes? How's my kidney and malnutrition going? Are there certain medications that I'm taking that's also depleting my ability to, retain moisture in the skin? So we're looking at that. We also know that, as we get older, especially, mentioning menopause, one of the factors that helps women keep our skin in hydration is estrogen. And with menopause, we lose that. So it's a lot of things that, we're balancing, trying to help, keep that luster in our skin. But, aging is, as I always say, it's not for the faint of heart. It's a blessing, but it doesn't come with its little trials. So, and also if you notice that, dry skin is also going to affect areas where we have the least amount of oil glands. So, That's why it's easy for, your hands and feet, and especially your lower legs, to get the driest and most irritated first, especially, with COVID. Everybody was extensively washing their hands, using a lot of hand sanitizers, and that's where they were coming with a lot of hand eczema and irritation, because there's no oil glands like you have, you have an abundant amount in your face and things like that. So ideally, in preventing or even treating dry skin, you want to, if there are any underlying conditions, you want to address that with your appropriate provider, whether that's a primary care or a specialist. But then you also, again, with lifestyle habits, you want to avoid any, frequent baths or showers. You want to, try to limit hot showers in the winter time, because again, that strips your natural skin oil and moisture. You want to use mild soaps such as Dove, Vanicream. These are Nature by Candace. These are very, natural, or I shouldn't say natural, but very mild and gentle soaps that are going to not strip and dry you out. And then the biggest key, I think, is using a daily moisturizer, especially right after you get out of the shower or bath while your skin is kind of damp. And yes, head to toe moisturizing every day is key. Okay. And I just put a compilation of, again, some of my favorite moisturizers. Uh, Neutrogena, Hydro Boost. I know everybody doesn't like different moisturizers. For the winter time, particularly, I'm more of a fan of the moisturizers that come in a jar. They tend to be cream based, which is more of a mixture of the lotion and ointment. Ointments are best, but I understand a lot of people don't want to be really greasy, and that's totally understandable. But the creams in the jar are going to be a little bit thicker, but not too greasy, and they're going to last you a little bit longer. Versus, if you're using a thinner lotion. Um, and then there are several options now. For instance, the La Roche-Posay Lipicar cleansing oil. I think CeraVe also has a cleansing oil where, if you want to use those in the shower, that are a little bit more moisturizing than, say, if you wanted to just use the Dove soap. That's a little bit more hydrating. I think one of the newer products that's out, if you are opposed or maybe allergic or not a fan of using any petrolatum products, or if you have an allergy to lanolin, the Aveeno Skin Relief Healing Ointment is pretty new, and I think that only has glycerin and shea butter. So, and it's a nice consistency. And then for guys that they don't really like the feeling of a cream or a lotion. I think the Hydro Boost is more gel, a little bit of gel with a cream, but it's moisturizing, but doesn't feel so oily or thick. So I think there's options that, several options out here that will help keep the skin moisturized and intact. And ideally, we're keeping the skin hydrated and moisturized so we can keep that skin barrier intact. Because remember, once that skin barrier is compromised, that opens you up to other, possible, superficial skin infections and et cetera. So we want to, avoid that. Next up, what we start to see commonly is eczema, also known as atopic dermatitis. So, this is kind of an innate condition. It can show up in childhood very often, but it can, I'm also seeing it a lot more in adulthood. And this is a chronic skin condition characterized by itching as well as severe dry skin. And it's associated with allergic rhinitis and asthma. Now, while we can't exactly pinpoint the cause of it, we do know that it's part of your immune system. And so we know that patients with eczema tend to lack a protein where they can retain moisture in their skin barrier and suffer from dry skin. We know that they tend to not be able to, um, you know, refrain from having hypersensitivity, or they do have hypersensitivity and not be able to cut off inflammation. And so their environmental triggers versus, a change in medicine, change in temperature, exposure to certain chemicals, to fragrances, to even certain foods can, trigger a flare or outbreak. And so we find that, these patients can have tend to be more prone to allergies. And those allergies can be anything from, certain foods like dairy, peanuts. There's a very common one that's the CAPB it's a coconut derivative that that's based in a lot of your shampoos, cosmetic products, nail products, things like that. And then the tixocordyl pivalate, that's in a lot of your steroid products. And we also know there's a very much genetic component of eczema. And so we know that, when someone's flaring with eczema, it can wreak havoc on your quality of life. It can wreak havoc with sleep, maybe your job, maybe even having time with your loved ones and family and friends. So, managing that is, can be difficult. And unfortunately, there really isn't a cure. But again, it's come a long way as far as treatment, but ideally keeping the skin barrier intact and making sure that we're, avoiding triggers as much as possible and minimizing stress and environmental allergens to lessen, the exacerbation as much as possible is key. And again, I wanted to emphasize that appropriate skincare is definitely critical. As much as you might enjoy, a certain perfume or cologne or your scented products or getting the nail or gel manicures or things like that, those you might have to forego if you're, especially during a flare, because you may not be necessarily allergic to it, but they can definitely, cause the flare to be worse. So, we want to be mindful of that. And, you kind of have to, treat your skin very gingerly or, treat it like you would a newborn baby somewhat. So there's definitely a lot more treatment options that we have now than when I first started for eczema. The old-fashioned treatment is, you give someone a topical steroid for a few weeks to really get their skin, that inflamed, itchy skin, to calm down. Because like I said, the more you scratch, the more you itch, the more you itch, the more you scratch, and it's just a vicious cycle. And that's how you end up with those horrible scars and, dark spots on the skin that's harder to get treated later and get rid of. So there was topical steroids, and then we moved on to non-topicals, non-steroid creams, such as your tacrolimus and pimecrolimus. Those are calcineurin inhibitors. And now we've moved on to some better medications that actually help to target the immune system, that can help quiet those cells that actually trigger the immune system to turn on those inflammatory responses from those triggers, like the environmental triggers. So, you may have seen the commercials for Dupixent or nemolizumab and or Opzelura certain medications that will help to, again, calm the inflammation, stop the itching, because if we can do that, then we can help, if we can relieve those symptoms, then we can help heal the skin better. And sometimes that also means giving a oral antihistamine like an Allegra or Zyrtec or Claritin to calm the skin down. And again, quite often from scratching leads to open, tiny little open wounds or fissures in the skin that leads to superficial infections. And if we can't clear that infection, oftentimes it's hard to cure that or treat the eczema, excuse me. And so sometimes we have to give topical and oral antibiotics to help um, clear the superficial infection to make the eczema better. And I find that for some patients, theirs flare a little bit worse in the winter because, again, eczema is, already attributed to dry, itchy, red, irritated skin. And in the wintertime, everything gets dried out even more. And I think lastly, I would be happy, and I'm sure the remainder of my team would be happy to see any of you guys for any of your needs at Sibley. But one of the things I always tell folks when you come in for a skin check, just some housekeeping when you come in, just be prepared to remove any makeup you might have. We want to make sure things go as smoothly as possible. We want to see your nails, fingernails, toenails, so make sure you've taken off all nail polish. For those gentlemen who have lots of body hair on the chest or back, just shave that down just a little bit so we can see those moles clearly. It's okay. I have several patients who might come in and they're really dry and might even be a little itchy. And they say, "Oh, I didn't put any lotion on today." That's okay. You can do that to put on lotion for me I can still see your moles and check your skin. Feel free to write down all your questions and concerns. It's okay to bring a list. We have patients that definitely do that. I even had a gentleman bring in a diagram. And absolutely bring a list of medications and supplements, especially if it's for rashes and things like that. And then for a skin cancer screening, just be mentally and emotionally prepared as for some patients, especially if it's your first visit, to remove all layers of clothing. You will be in a gown, and we try to help make you as comfortable as possible, but just in the wintertime, especially be prepared to remove all layers of clothing. And this is our Johns Hopkins Sibley Memorial Team. We have Dr. Kevin Charney, our medical director, Ms. Deborah Horitz, myself, and then our newest team member, Dr. Yosef Dahlia. And we are here again at Sibley Hospital, Building A, Suite 140, happy to serve all of you all with all your dermatology needs. And I do think that's it for me. Oh, Elaine, I think you're still muted.
Thank you. Thanks so much. That was great. I have there was one question. I love
Yes,
how every dermatologist or physician's assistant I talk to that specializes in dermatology always recommends La Roche-Posay and what is the other one? CeraVe.
survey.
I wonder if there's is there something we don't know to save our money from purchasing all those other skincare because it seems like those two are consistently recommended.
Really? No, I don't think so. My new favorite one is actually Avène. So those, they're CeraVe and La Roche-Posay. I don't know if people know that they're actually under the same umbrella of L'Oreal.
Hmm, who knew?
But I don't know. I don't know if maybe they just market a little more, but Cetaphil is one of my favorite also. That's
Oh yeah,
probably,
Cetaphil too.
I think because I can go to Costco and get it.
I think they're also just really affordable as well.
Exactly. So
Yeah.
you can't go wrong, and it's pretty gentle, and it's a very good moisturizer, the one in the jar from Costco. So, but I think Aven for it, which is a French product, but it's very good for sensitive skin.
Okay.
So yeah, but I think maybe they just market a little better.
Maybe. Um,
But they're good. But they're good. They have good product though.
yeah, they have good products. Yeah, they do. I use, well, anyway, I won't talk about my products, but anyway, so someone wrote in the chat, is Lancome cream a good one? Lancome.
Mhm.
Lancome or Lancome?
Is there a particular, I can't speak for Lancome. I haven't really used it. Is there a particular product you're asking about directly?
I don't
That
know.
you-
That's what Miss Jane Bajord wrote. So I don't know.
Mhm.
Maybe do
Mhm.
you have anything else? Um, uh, I don't know. But Alessandra says, thank you for the useful presentation. For dry skin, would you recommend avoiding using loofah sponges or exfoliating gloves while showering?
No, I think it's great. Absolutely love that for you don't necessarily need it every day.
Ah,
But I think it's a great idea to I use it myself. But not every day during the winter. But that no, loofahs are those are great idea for the winter. Especially with a moisturizing, good hydrating, even maybe even the cleansing oil. But yeah, absolutely.
mm, mm-hmm.
Mhm.
Yeah, and also after getting out of a shower or bath, would it be helpful to also moisturize then or to dry off and then moisturize?
You could, I usually say my rule of thumb is you could pat dry, but
Hmm.
while the skin is still moist. So don't completely dry, but while the skin is still moist, then moisturize because you want to lock in while your skin still has some of that moisture. That's the best way.
Good to know. Does anyone else have any other questions? Now is your time to ask all those skin related questions. Um, I had one. What
Yeah.
is the best time to get a skin check? Is it when's the best time? In the winter time?
The best time is whenever you're going to consistently come.
Okay.
So if it's easy for you to remember around your birthday, that's fine. If it's easy for you, if you prefer not to have to take off a bunch of layers of clothing and you want to come in the summer, that's fine as well. Ideally, the American Academy, excuse me, of Dermatology recommends that anyone 50 and up should be coming yearly.
Oh,
Or
oh, oh.
of melanoma, we recommend you probably should come earlier than that. Or if you've had a history of skin cancer or melanoma, or if you've been diagnosed ever with a atypical or dysplastic nevus. I didn't go too much into that.
Mm-hmm.
That could be a lecture in
Yeah.
and of itself, but then we recommend, of course, like with anything else, you were screened earlier. But yeah, I typically recommend, if you're more of a summer person and you don't want to because some patients, rightfully so, they're like, I don't want to come in and have to undress in all those layers. May is Melanoma Awareness Month, so some people like to come in more so during that. A lot of the academic centers even give out free skin checks on
Mm-hmm.
that Melanoma Monday, which is the first Monday of May.
Mm-hmm.
So that might be a key time to go. But I just say at least if you're, and then some people go when they see their primary care and they have their regular yearly checkup then, and then the primary care. I often get a lot of referrals from the PCP who says, oh, I'm seeing you now for your physical. Let me put in a referral to see your dermatologist for your skin check.
Great. I just got my skin check and I got A plus. I'm like, yep,
There you go. Love
wearing
it.
my
Yeah.
sunscreen, right?
Yeah. Yeah. Yeah.
Um,
Awesome.
oh, and one of the reasons why I went is for this next reason. This participant asked that they have brown sunspots on their face, what can they do
Mhm.
about it?
Brown spot. So one, I would verify with the dermatologist just to get it checked out that make sure those like more than likely they're probably just sunspots or those or what we call lentigos or lentigines, which are just sunspots. But sometimes those brown spots it might be hyperpigmentation or melasma. So I just want to make sure you get it checked out to make sure it's not something else. But if they are just brown spots, then there's treatment that we can do for that. Either it might be a retinol or retin-A kind of product, or it might be some hydroquinone or skin lightening product, or even laser. So it's just a matter of getting it checked out. But in the meantime, the key is making sure you're doing sunscreen protection hat to make sure it doesn't get any worse.
And then how much sunscreen, like in the summertime, how much sunscreen is like sufficient? Because I think like sometimes we just put like a little bit and we rub it and we think that's
Mhm.
gonna do it. But how much is like, how much do we really need?
Great question. So you've probably seen one, let me just make this disclaimer. Sunscreen should be worn year round.
Mm-hmm.
And I think that's another misnomer that people have. And they're like, I'm asking, are you wearing your sunscreen? Oh, I'm not laying out. Well, anybody that's driven around in the DMV traffic, you can go, 5 miles and be in a car for 30 minutes. So you want to make sure even you're getting enough of that UV through that windshield that you should at least have it on anything that's exposed. So you're putting enough on your face and on your hands that you're protecting yourself. So it should be SPF 30 or higher, and it should be broad spectrum.
Mm-hmm.
And you want to think of a shot glass amount that's for wherever you're applying it. Okay. They're one of the reasons why we have this range of, SPF 30, 50, 70, 100 is because it's not so much that you're getting more coverage if you use 100 versus 30. It's just because people weren't putting enough.
Mm-hmm.
Um, so scientifically, if Eleni, if you're putting on 100 and someone else is putting on 30, it's not that you're getting more coverage. It's just that the person that was putting on 30 wasn't putting on enough. So they bumped it up so that you're probably putting on the same amount. It's not the equivalent. And, if you're putting on 30 and you're putting a sub level, then that 30 might be the equivalent of a 20 SPF. So they bumped it up to 50 so that even if you miss the mark of how much you should be putting on per body part or body or what we call body surface area, you're getting enough. Okay. So and then the other key part is making sure you're reapplying it. So some people, they will apply it or it's in their makeup or moisturizer. But then if you happen to go out for a walk or eat lunch outside or walk the pet, you forget to reapply it. So that's the other key part, you want to reapply.
Yeah, reapplying is key, especially when um you're like at the beach and you're like out and you're swimming and you're perspiring and yeah, you have to definitely reapply. Um, one of the questions um that I wonder so one of the things I wonder about, and this is also related to this question, is in the wintertime we're all bundled up and the little bit of skin that we do have exposed to the sun. Does the sunscreen prevent us from building up vitamin D? Because vitamin D is processed through our skin, correct?
Great question. Yeah. So a lot of the times, yes, we get a little deficient. It's not uncommon because we're inside. And so that's why it's important either, supplementation or diet that we're getting that. Even some of us with, such as myself with a little more melanin, I'm not getting as much
Mm.
um as someone with a lighter hue of skin. But yeah, so that's another key. Yeah, I think we do in the winter months, we're not outside as much. or we are bundled up. So yes, we are probably for those if you're not taking an extra supplement or it's not coming in your diet as much, you're maybe a little bit vitamin D deficient. And I do see that a lot because I also see a lot of hair loss, and I'm
Mm.
definitely checking that. So that is key. But I always say a lot of the times you still want to be mindful of protecting that skin. Because even if think of you're doing winter sports and things like that, snow is reflecting that sun, so you can, have frost or, you still can burn. So we still want to be mindful of protecting that skin.
And then when you put the sunscreen on, does it block also the body's ability to absorb that or to create the vitamin D? Like,
Not
is it
not create. You just won't,
met
you're definitely not getting as much.
okay, metas not metas me-
Metabolize.
there you go. That's the word. I'm like, not metastasis. Okay, there you go. All right, thank you. Um, were there any other questions? Um, Now I also just want to preface that you're not like recommending all these creams because of like you're just giving what am I trying to say? You're just giving recommendations, but not recommending a certain one, correct?
No, just giving recommendations. These are some of the ones that we give out in clinic. Full disclosures,
Yeah, there you go.
I have no stock. I have
No stock
no,
in CeraVe.
nothing. I'm not
Yeah,
getting paid by any of these companies, nothing.
I think also sometimes the things that our mothers and grandmothers used, I think, those things work and they worked for a good reason. I don't think you need to,
Absolutely. Yeah. Good old fashioned Vaseline, shea butter, cocoa butter, just good old fashioned moisturizer.
yeah,
It really helps.
yeah. Um,
Um, Staying on top of it, yeah.
and getting the skin checks.
Yeah.
I wondered, do you find that you're seeing less people with skin cancer because people are using sunscreen?
Do I find that I'm seeing less skin
Less
cancer?
folks without like are you finding that you find how do I want to say this? Are you finding that people that you, are you finding that you're seeing less skin cancer on people than you had prior years because of the use of sunscreen?
Great question. I don't know that. I think I'm finding that our communities are more educated
Okay.
and more aware. Because I think I'm still seeing a lot of our baby boomers
Mm, mm.
and that generation, and I always say, I don't fuss because, that generation didn't know better, right? That this was a generation that also smoked in hospitals, I always jokingly say, right? So, this was before sunscreen really came out and it was available, and this was, the holding in reflects the reflectors up in tanning oil. So this was, so I think not as much, I don't know that I'm seeing less skin cancer
Okay.
quite yet. I think
Okay.
probably in the next generation or so, I think that people are smarter, and that they're more educated and aware. But I think I'm still seeing a lot of our baby boomers that are now coming in because these slower basal cells, squamous cells, they take 40, 50, 60 years
Mm.
to show up. So now my more mature patients that are coming in at 70, 80, 90 are now showing up with skin cancers.
Okay.
At this point, you've kind of earned one. And but yeah, so I think maybe the next generation that will probably be the case.
Okay.
Mhm.
Um, we have another question from our audience. Should you use a different, this is a good one. Should you use a different moisturizer for your face than for your body?
Great question. Um, yes, I think if you are a patient who is more acne prone, I think you should definitely use a different moisturizer for your face than for the body. And you want to, the key is to look for facial moisturizers that say oil-free or
Mm,
non-comedogenic. Um, if you are not acne prone, then you are probably, at least during the wintertime, okay to use the same, at least in the wintertime. In the summertime, the that heavier moisturizer might be too much on the face that you use on the body. But now there's a plethora of facial moisturizers that have sunscreen in it. I'm when I always say with the skin, less is more. I like to do, especially in the morning on the way to clinic. I'm very much about the less I have to do with a skin regimen and routine, the better. So if I can reduce a step with, cleansing and putting on a medication and then do a face moisturizer that already has a sunscreen in it, bingo, bango, and I'm out the door and I'm done. So, but in the wintertime, things get a little drier. So if you're not acne prone, you could probably use it, but there are a plethora of facial moisturizers. But for acne prone skin, I'm definitely recommending just using a face moisturizer that is either oil-free or non-comedogenic. Great question.
great. Why are we more acne prone as we age?
Great question. Several factors to that. Usually hormonal,
Mm,
menopause, unfortunately. In our medications, I have patients that might be, whether they're on whatever type of hormone therapy that can cause it. Stress.
mm,
From hormone therapy to chemotherapy, there's just tons of medications and hormone changes and stress that can and diet. I always tell patients think of, as much as I love dairy, but dairy comes from a lactating cow, which brings in more hormones. So sometimes, I by all means am not encouraging anyone to go vegan, but sometimes you might have to do things again in moderation. But what after, teenagers, I usually see things like that. And then also, there's um again, lifestyle things. Sometimes I think, again, we might do too much, on this age of TikTok medicine, as I call it.
mm.
Patients coming in and they're using snail mucin and they're toners. And there's patients that are doing like 12 to 15 steps for their skincare regimen. And sometimes when you're doing too much, it can you're you think you're drying this out and your skin responds to it and our skin is made to produce oil and it's made to heal itself and sometimes if we do too much it's gonna try to compensate for that and then sometimes we cause more irritation and inflammation and so I think sometimes it's just even the products that we use that cause it to get out of whack as
Mm.
well. Mhm.
Yeah, less is more.
Yeah.
Less is more definitely. I I was asking because you did mention about hair loss. Why
Mhm.
are there so why are why do women lose their hair? Why do people lose not why do people, men and women, but lose their hair as they age? And then what can we do to prevent or even regrowth?
Great question. So yeah, I spend a lot of time with my hair loss visits. That's even just a separate visit. I only do that I don't do anything else during the hair
Uh-huh.
loss visit because that's a pretty extensive consult. So there's different types of hair loss, multiple types of hair loss. I don't think people probably sometimes realize that, but a lot of the times when it's male and female hair loss as we get older, a lot of times that's what we call androgenetic or female pattern or male pattern hair loss. And that's usually just your genetics
Mm-hmm.
and hormones, menopause, male menopause. So,
Uh-huh.
um, in the case of genetics, you can't really prevent it. You can kind of start early treatment to try to get
Mm.
ahead of it. But again, I always tell patients the one things we can't control is how we are aging, and we can't control genetics, right? So, I'm always someone that I want to make sure that I'm checking, first of all, everything internally to make sure there's nothing underlying that's contributing to this hair loss, because oftentimes that can happen, and that can range from anything to autoimmune to like thyroid and lupus to, I'm checking your hormone panels, I'm checking your vitamin panels, um, I'm going through your, any surgeries and hospitalizations, any other illnesses, your medications, your supplements, um, because, let's face it, in this era of GLP-1s and weight loss, that can cause. But so I want to make sure anything underlying that can be contributing to hair loss is addressed. And then, and then there's other parts of hair loss that, can be um, caused due to scarring types of hair loss or inflammation. And that's a little bit more in depth. That might involve, biopsies of the scalp, that might involve other treatments, more in-depth treatments like, antibiotics or, anti-inflammatories and, more serious medications and injections and things like that. So, but I think the most common type of, male pattern or female pattern hair loss that, that might be nutraceuticals, like certain type of vitamins, like you've heard of, maybe Nutrafol or Viviscal, or there's
Mm-hmm. Mm-hmm.
stress. And then there, in those cases like minoxidil or finasteride or dutastirides that help to block DHT, those medicines work very well to get the hair back. But I also have to tell patients, that's you got to welcome to your new era of kind of being on that type of medication, and that's barring that you're not on any, other blood pressure medications, or there's been no other history of, breast cancer. So, there's, risk
Yeah.
and benefits of things like that. So it's an in-depth visit, and, and realistically going through the patient and figuring out, hey, what's your goals and with the hair loss and what bothers you and concerns, and in the end, if that might be for someone that's more natural, that might be, PRP, where we draw the blood and spin it down and get the plasma and put that injected. Or if someone that just says, oh, we might need to refer you off for a hair transplant, different
Yeah.
options like that. So yeah, that's but the simplest one is the the genetic component of it, unfortunately.
Yeah, maybe we should have another talk just on hair loss.
Good. Could spend a few days on that.
Yeah. Well, thank you so much for your time. I
Welcome.
appreciate your time.
Absolutely.
And thank you to everyone who joined in this afternoon. And just thank you again, and stay healthy, stay well, and stay hydrated, and thank you. Thank you, everyone.
Thank you all. Thank you all for taking the time to be with me this afternoon. I wish you all a very happy and safe holiday season.
Yeah.
Thank you, Lainey.
Thank you. Bye, everyone.